All right, so we're going to start off with pediatric conditions, but you can't miss. Does anybody here have experience in pediatrics working with children at all? What kind of crowd are we working with here? Oh, we got someone in the way back there. All right. What have you done? Have you done rotations, worked with children? Okay. All right. So great. Anybody else here work with children at all? A little bit here and there. All right. So a relatively pediatric novice crowd. I want this to be I'm going to go through some cases. I want this to be as informal as possible. I want you guys to chime up, speak up, raise your hands, scream out. You'll notice as you go through these slides, it's enormously ambitious what I intend to cover over the next 45 minutes. There's no way I'm going to get through all of it, but I prefer that we have good discussion and good conversation. So if you have questions, I'm going to be asking for your participation. If there's anything you want to chime in and say, as random as it may seem, I don't really care. That's fine. The more random, the better. I urge you guys to do that. All right. So let's get started. So real quickly, people always ask me, so why did you choose pediatrics? We have an MS4, we have a fourth year medical student in the back who I get asked from med students, PAs all the time, NPs, why did you choose pediatrics? And so I figured I'd just cover this real quickly up front. So when I was in med school, I quickly discerned that surgery was not for me. Nobody wanted me to be their surgeon. My wife is a surgeon. She's excellent at what she does. I, on the other hand, had absolutely no aptitude for anything that required my hands. So I knew I was going for something diagnostic between medicine and pediatrics. I liked pediatrics because of the diversity. And I know there's a lot of diversity in internal medicine, but I like the age diversity. You go from 0 all the way to 21. You know, last week in clinic, I saw a newborn, and then I go in and I'm dealing with a teenager with a completely different set of issues. And so your mindset has to change, your diagnostic range has to change. I enjoyed that diversity a lot. I liked having to change clinical thinking. Parents and families, a lot of, I am a parent. I am one of those obnoxious parents that goes into their pediatrician, believe it or not, too much. My pediatrician even looks at me sometimes and says, why are you here when I bring my child in? Because as a parent, you're concerned all the time. I actually enjoy conversations with parents who are very concerned. I like being able to bring solace to families. A lot of what I do is actually reassurance, so I'm a nephrologist as well, so the acuity of illness I deal with as a nephrologist is a little bit different than I do as a general pediatrician, but still, a lot of what I do is bringing solace to parents, and I enjoy that. I enjoy those conversations a lot. Continuity, right, that's self-explanatory. Major difference between children and adults is one chief complaint, right? So when you're dealing with adults, multiple comorbidities, everybody in the world of adults knows this. You come in, you get a list of medications, multiple hospitalizations, and extensive past medical history, and you have to kind of sort through that. I'm not smart enough to do that. So pediatrics is easy, all right? So parents come in and they give you a whole spiel, they give you a long story and an incredibly long narrative, and sometimes it's hard to piece it together. What I've filtered out over the past few years and what's made it easier for me is what I'll ask parents is, okay, let's break this down to one thing. Tell me what bothers you the most. Your kid is coughing, your kid is wheezing, they're feeling tired, their left toe is hurting. Of all of those things, what bothers your child or what bothers you the most? And you can always revolve your differential diagnosis around that chief complaint. That's one thing about pediatrics. So if you're seeing a child in the ER and the parent is coming in and they are absolutely panicking, right? If it's an acute situation, obviously you deal with that immediately, but if you have time to create a differential diagnosis, pick one chief complaint. Ask the parent what bothers you most, and it will save you time and it will make your line of thought much easier, okay? Because then you can create your differential diagnosis around that one chief complaint. And finally, for me, the cuteness factor and smell. Between pediatrics and adults, I know that sounds superficial and ridiculous, but actually children, they're cuter, they smell better. It's easier to garner compassion for a small child sometimes also. When you're dealing with difficult parents, it's always important to be able to take a step back, not take things personally. Nobody's at their best. In fact, parents are at their absolute worst when their child is sick, especially when they're acutely ill. And being able to refocus your attention on the child always is easier. It's easy to do, and it's very, very important. That picture on the right is after a 36-hour shift. I am, in fact, drinking from a bedside urine container. We've all been there, right? No, we've not been there? All right, so yeah, I'd like to throw that picture in there. Okay, so those are just some reasons. All right, so let's start off. So you have a baby that comes into the ER. This is something I see every single day in clinic and see in the hospital. All right, your job working in the ER is to make that primary assessment, all right? And this is what I teach my students right up front. When you look at that baby, right, your job, 90% of your physical exam in pediatrics is just gonna be observing that child. What do you see when you look at this baby? Scream it out. What do you look at? What are some of the things you're looking at as a clinician? What? Looks mottled a little bit, right? Anything else you guys notice? It's not a dynamic picture, right? So you can't see how the baby's breathing. I'm sorry, what were you going to say?
I was going to say maybe some asymmetry in its chest, but it's hard to tell because of how it's laying.
Okay, good. Anything normal you notice about this baby? Good, you guys are looking for pathology, and that's important. What about normal things that you notice on this baby?
I think he's doing a moro.
Doing a moro, okay? So that could be a primitive reflex that you're looking at. So when I look at babies, or when I look at children, smaller children, infants in particular, I tell students there are three things you should notice. I know this child looks mottled. It's a bad picture, but actually the child is pretty pink if I could show the less grainy picture. So I tell students always, look at color, tone, respiratory effort. Those are the three things when an infant walks in every single time. That is 90 to 95% of your exam. If you can discern that those three things are normal, put on your stethoscope, look like a provider, walk into the room, look professional, but most of your exam has already been done just by doing those three things. There are lots of bad colors, right? There's blue color, there's red color, there's yellow color, there's if you can discern what's good and what's bad with regard to color, that's important. Tone, right? So it looks like a moro reflex, but actually this is a baby that is not hypertonic. Infants that are newborns actually are relatively hypertonic, right? So this is actually good tone for a baby. If they're looking floppy, if they're looking listless, that's bad. And then respiratory effort. What are some of the signs of respiratory distress that you might be looking for in an infant? Yeah, what else? Scream it out, what? Grunting, right. What does grunting mean, by the way? Physiologically, why do people grunt when they're in respiratory distress? Is there a physiologic reason why people grunt when they're in respiratory distress? Say it again. Excellent, very good. So did everybody hear that? Anybody understand that? So that's, when people are breathing out like that, babies, infants in particular, every time they breathe out, that's called grunting. They're self-peeping, that's positive end expiratory pressure. What's happening is their airways are collapsing when they're expiring, and they keep that airway open, or they stand the best chance of keeping that airway open if they reverberate pressure back against the epiglottis into the pulmonary parenchyma, into the lung itself, right? And anything else, so we see nasal flaring a lot in kids also, another sign of respiratory distress, all right? So color, tone, respiratory effort, that's your first assessment when you look at a baby. If those things all look fine, you can breathe a sigh of relief. Now you have time to think about what's actually going on with that child. One of the things I do when I'm standing outside the office, even before I see the child, is I just listen. And again, powers of observation are very, very important when you're examining infants, all right? When I hear that cry, when I'm sitting in my office, either writing my note or on the phone, talking to whoever it is, as soon as I hear that cry from that infant that's brought in, I know a lot about that child. Is that cry loud and robust? Is it hoarse? Is it high-pitched? Is it weak? Again, a huge part of my exam is simply from hearing that child. So again, how that child looks, how they're breathing, their color, their tone, what they sound like is a good portion of your exam. All right? If those things are fine, you can take a step back and you have time to think. The other thing you have to do in pediatrics is recalibrate yourself. All right? What's the normal, without looking at this up there and your charts, what's the normal respiratory rate for an adult? How many breaths per minute?
14, 20.
Yeah, it's 14 to 20, 12 sometimes. 12 to 16 is roughly usually what I think of. How about a newborn infant? They routinely breathe at 60, all right? They have a higher FRC, functional residual capacity. They routinely breathe at 60, okay? So looking at children, you have to completely recalibrate yourself. When you see an infant that's breathing at 40 to 60 breaths per minute, don't freak out. Actually, that's probably normal, and you're looking for your other signs of respiratory distress. How about heart rates? Your normal heart rate for a newborn is somewhere between 90 and 160. They go all the way up to 170 and up to 200 when they're really upset. If you saw that at an 18 to 25 or 55-year-old, you'd be pretty nervous about it. So recalibrating yourself when you look at vital signs is very important, and knowing what those norms are, okay? All right, let's start with our first case. Well, actually, yeah, so let's just look at vital signs, for instance, all right? All right, so you have a 3-year-old presents to your office for a well check. Let's look at those vital signs. What on those vital signs sticks out to you? Anything stick out? Temperature looks pretty good. Pulse in a 3-year-old 90, is that tachycardic? No, it's 3, that's fine. Breathing at 26, we now have recalibrated ourselves for the 3-year-old. That's not bad, that's actually pretty good. And if you have to look at your chart the first few times, that's fine. How about the blood pressure? That's high. For a 3-year-old that walks in 118 over 78, right? Everybody over the age of 13, 120 over 80 is where you'd like them to be. But for a 3-year-old to have 118 over 78, that's high. How do you know it's high? Intuitively, you might look at that and say, that's high, right? That's a blood pressure you should see in an adult. You shouldn't see that in a 3-year-old. How do you empirically know that that's a normal blood pressure? That's not a normal blood pressure for a 3-year-old. Does anybody know? Well, we've created this wonderfully dizzying chart. Don't try to read it. Has anybody ever seen this before? Does this look vaguely familiar to anybody? So we have created norms for blood pressure for all children between the ages of 1 and 13. It was first put out in 2004. It was called the Fourth Report for Hypertension. It was recently revised about a month ago, actually, in 2017. So for age, sex, and height, we have normalized blood pressures for every single age. And you're always looking, the normal blood pressure is under the 90th percentile, right? So when that 3-year-old comes in with a 118 over 78, and you intuitively correctly assume that that's high, you now know where to go empirically to look for that. What are normal blood pressures for that age? Okay, so knowing about this chart's existence puts you a step ahead of the game. Most people don't even know this thing is out there. It's important that you know it is in fact out there. All right. This was the overambitious list of objectives that I had to go through for the day. Respiratory emergencies, fever and rash, other pediatric rashes, altered mental status, pediatric dehydration, and unopposed vomiting. I'm not sure we're going to get to all those. Probably won't, but we'll do the best we can. All right, first case. Father brings in a 10-month-old son for difficulty breathing, especially at night. And he's got a barky cough, right? That's a great buzzword. Remember, they don't come in telling you, I've got a barky cough, although sometimes the parents will say that. He does have a barky cough, but the kids certainly won't say that. Mixed with some URI symptoms, observing him, you observe suprasternal retractions and wheezing sounds on inspiration. What do we call that clinically? What does that sound like clinically? Clinically, what do we refer to that clinical finding as? Suprasternal retraction, stridor, all right? Why does stridor happen physiologically? That's right, I'm going to push you through pathophysiology at 8:15 in the morning. Why does stridor happen? Because if you understand why it happens, then you can understand that there's a broad differential diagnosis. When you look at this and hear this case, what's your diagnosis? Knee jerk. Barky cough, stridor, croup, right? Right off the bat. That's what you think, right? But your job as practitioners, as PAs, MPs, as physicians, your job is to think more broadly than that. You are not going to be routinized thinkers. You are going to be people that think across the spectrum. Your job every time a child walks in is to think, what can kill this child? I don't care if they come in with a runny nose. Your job is to think as broadly as possible, quickly cross those things off your differential diagnosis, and then you have time to think about the less ominous things, all right? So croup jumps into your mind, and croup can be ominous, but as a provider, you're going to think of 15 other things this could be as well. And if you understand the pathophysiology behind it, it becomes easier to think of those 15 other things. So why does stridor happen pathophysiologically? So what is it? What's the sound you're hearing? I'll give you the answer to that one. It's reverberation of the large airways, the trachea and bronchi, right? So you're hearing reverberation of those walls. Why does that happen? What's happening? Any words come to mind? Anybody? Airway obstruction, right? So that obstruction narrows that airway. What happens when you narrow that airway? Bernoulli's principle, sorry to put that up there this morning, I apologize, but it makes a lot of sense intuitively. If you narrow the airway, you increase the velocity of the air moving through it. Every time we inspire, there's some bit of collapse of our airway just because we create a virtual negative pressure compared to atmospheric pressure outside our airway, right? Every time we breathe in. Now you critically obstruct that airway, you increase the velocity of that airway, you drop the pressure even further, you further decrease negative pressure, that airway collapses even more. And suddenly, you're making that noise and you're seeing that airway collapse when they breathe in. Really high or low negative pressure inside that airway, all right? Now they start freaking out because they can't breathe in, and they make it worse. That obstruction, that velocity moves faster, that negative pressure drops, and if they're agitated, you'll see it even more. And in croup kids, when they're really upset, you try to keep them as calm as possible, as well as in other upper airway obstructive problems. You'll notice that the suprasternal retractions become worse. So that's why it happens, And it can happen on expiration as well as inspiration, where it depends on where the obstruction is, if it's intrathoracic or extrathoracic. But we're going to focus on extrathoracic because that's way more common. All right? So your differential diagnosis. What can't you miss? We threw out croup because knee-jerk, we thought it was croup. What else can cause upper airway obstruction? Excellent, and we'll go through epiglottitis. You know what, let's just skip right over there now. What used to be the most common cause of epiglottitis? Has anybody here ever seen epiglottitis? You have, excellent. In the world of adults, right? So what's the most common cause in adults? Do you guys know what the most common bacterial cause of epiglottitis in adults is? Actually, it can be viral as well. H-flu in kids. In adults, actually, it's become staph and strep. But believe it or not, we're starting to see H-flu epiglottitis again. I would say about 10 to 25% of my practice right now, there's vaccine hesitancy to refusal in my practice. We will start seeing these diseases again, I promise you. So you need to be aware from them. There'll probably be a rush to the door afterwards and people will start revaccinated, but we're probably gonna have to see the cycle of these diseases again. Typeable, type B H-flu, which is different than non-typeable. Typeable B H-flu, most common cause of epiglottitis in children, okay? So epiglottitis is on your differential diagnosis. What else can cause it? Bacterial tracheitis, excellent, good. What else? Foreign body, big one in kids. Got to remember that one every single time. Anaphylaxis, ingestion is a big one in kids too. Kids are not smart. They see something, they want to drink it. They don't care how it tastes sometimes. Although they do care. Sometimes that's what saves you, is that when they do care what it tastes like. Burns are important to consider in kids, all right? All these things, even though your knee-jerk diagnosis is croup, you need to think broadly as possible. And the rest. There's a whole bunch of them that are less ominous, so I would divide it between acute and chronic, right? So laryngeal malacia is a common cause, and sometimes laryngeal malacia is sometimes when kids lay down because their larynx is still cartilaginous, it's not solid yet. Every time they lay down, it'll look like they have airway collapse. Very, very common in children. How you assess it, right? Whether or not you're going to jump in, this is your specialty, right? The great thing about diseases, every single disease, is regardless of its etiology, it all comes down to ABCs. In the ER, you don't care, right? Your job is airway, breathing, circulation, or in adults, CABs, or older children, right? It's now CABs, right? It's changed a little bit. So it all comes down to those three main things. If you have a kid that's really in severe respiratory distress, that's what you're going to focus on first, and you don't really care about the diagnosis at that time. So back to our case, 10-month-old male, prodromal URI symptoms, barky cough, stridor. We got the diagnosis, it's croup. How do you manage it? How do you manage croup? Someone said steroids. Is that the first thing you're thinking of? What else? Racemic epinephrine. How do you decide whether or not you're going to use racemic epinephrine or steroids? How do you make that basic discernment? Stridor. But stridor at rest in particular, right? So that's just some epidemiology about croup. By the way, we'll get to the management in 1 second. That's a characteristic sign that you'll see on radiograph. Croup is a clinical diagnosis. You don't need radiographs. You don't need x-rays. But what do you guys notice on this x-ray? Do you see the narrowing there? Steeple sign, right? Referred to as the steeple sign. So stridor at rest is how you're going to make that basic distinction as to whether or not as to how aggressive you're going to be. If a child is sitting there and they look like they're comfortable without stridor, but the parents report a barky cough, probably not a whole heck of a lot you need to do right then and there. If a kid has stridor at rest, that's when you're going to pull out your racemic epinephrine. The reason you're not going to think about steroids initially first, right? Steroids are a great thing to have on board, but steroids don't work acutely, right? They don't work right off the bat. So racemic epinephrine is going to work really, really quickly because of all the adrenergic receptors it works on. All right? Steroids buys you time because the croup is probably going to last another 36 to 72 hours, and so that'll reduce inflammation in the airway. Other things you can use that you guys are familiar with, Heliox. Anybody ever used Heliox in the emergency room? Zach, you ever used Heliox in the emergency room before? Okay, so kids that have Heliox is air, but with lower viscosity. It's got helium right in it. So it's air with lower viscosity, so you have an obstructed airway. It actually is less turbulent in the way it flows, so it can flow through more easily. And we've actually used Heliox before to get through that airway. And it works really, really well, and it doesn't give them a high voice or anything like that. Another can't miss, right? So we talked about this diagnosis. What is this kid doing? He's tripoding. What does tripoding do? Why do they tripod? Opens up that airway more. It's a sniffing position. They tripod so they're in the sniffing position, commonly seen in a kid that really looks scared, and you'll see it in epiglottitis. And that's what an epiglottis can look like in epiglottitis. Most common cause used to be H. flu. We'll start to see it again. Abrupt onset, they look anxious, restless, irritable. There are some complications. It's an airway emergency. If you see a kid that's in the tripod position in the emergency room, they're looking scared, they're looking upset, talk quietly, whisper, tiptoe up to them. Don't agitate them, and call ENT or somebody with airway specialty or anesthesiology as fast as possible, unless you have specific expertise in dealing with epiglottitis and intubating. A kid that's irritable and upset and nervous, call to set up for the OR as soon as possible, all right? And then, of course, you can use broad coverage antimicrobial therapy. That's called the thumb sign. That's a lateral radiograph where you can see the swollen epiglottis, and we call that the thumb sign. All right, let's move on to the next one. How am I doing on time? 8:30. 4-month-old X28-weeker presents coughing and clear respiratory distress. You call a code, scanning him, you notice rhinorrhea with extensive accessory muscle use. I will say, in this particular case, you don't have anything clinically that sounds like airway obstruction. What you're seeing looks like lower airway respiratory distress. You auscultate very little air movement with intermittent wheezing. There is some adventitious sound, enough air movement to create adventitious sound, and it's without focality. These are your vital signs, all right? 39.1, he's febrile, his pulse is a little bit elevated even for a 4-month-old. He's breathing at 70, and now that we know to recalibrate ourselves, that's pretty fast for a 4-month-old. That's definitely up there. His blood pressure is a little bit on the higher side, and he is hypoxic. He's at 84%. Differential diagnosis. What are you guys thinking? Knee-jerk response. Foreign body. Great. Excellent. What else? Now we start. What's that? RSV. RSV is a cause of bronchiolitis. What else can do it? All the same things that are on the differential diagnosis before. Anaphylaxis. You can distinguish between infectious causes and non-infectious causes. All right, pneumonia, bronchiolitis, anaphylaxis, airway obstruction, always in children. Pneumothorax, don't forget the other stuff that you guys deal with in adults, pulmonary embolus, cardiac tamponade, trauma inhalation. The other thing, always to remember, and this is just something that I have as habit, if I see anybody that's tachypnic, and the tachypnic is different than respiratory distress, it's a sign of respiratory distress, but if you see pure tachypnea without accessory muscle use, metabolic acidosis always needs to be on your differential diagnosis, because the compensatory alkalosis can lead to tachypnea, not necessarily the respiratory distress. So if you see a tachypnic patient with good air movement, no adventitious sounds, but you can't figure out why are they tachypnic, do a metabolic panel. Keep metabolic acidosis in the back of your head, all right? So the diagnosis here is bronchiolitis. We start to take context. When you are creating a differential diagnosis, try to throw all the details that the parents are throwing at you, and in general, with a history, parents are going to throw tons of details. Well, on Tuesday he had a cough. On Wednesday he ate a cup of applesauce. On Thursday, they're going to throw a lot of details at you. Again, pediatrics, sorry, ma'am. What is it that bothers you the most? And again, you have a kid in respiratory distress here, so your chief complaint is respiratory distress. Eliminate all other demographic, all other pieces of information, and first create your differential diagnosis so you don't miss something, and then start adding in your details. Well, this is a 4-month-old ex-preemie, right? High risk for this condition, bronchiolitis. The most common cause in children of bronchiolitis, as you mentioned, being RSV, and there are 2 subtypes in particular, right? It is the most common cause for hospitalization that we see in children under the ages of 2 during the winter time. Prematurity, chronic lung disease, chronic congenital heart disease, neurodisease, all risk factors for bronchiolitis, and those are your most common cause, RSV being about 20 times more common than the rest of them, respiratory syncytial virus. All right? There's always a URI prodrome. They usually present to you at days 3 to 5. Usually when they present to you, it's when they're at their peak. And if they're not that bad, you can usually allay the parents' concerns by saying it's going to get better after this. This is what you're going to watch. This is what you're going to watch for, but it's probably going to get better. They almost always bring it into the ER when it's at its absolute worst, which is on days 3 to 5 of symptoms. The symptoms, by the way, afterwards last forever, like 14 to 28 days. Those kids have a cough. Their parents are worried about them, and they come in day after day after day up to 14 to 28 days. How are you going to decide whether or not you're going to intervene immediately? Well, it depends on that degree of respiratory distress, right? This kid is 84%. You're definitely going to do something about that. You see your intercostal retractions, you see suprasternal retractions, they're grunting, they're flaring. You need to intervene immediately. And what is your primary intervention for bronchiolitis? Anybody? Bueller? Anybody? Supportive. Who said that? Excellent, right? How about bronchodilators? No, it's really usually bronchodilators, beta-2 agonists. Basically, for the most part, it depends, but 99% of the time, don't have a place in RSV bronchiolitis. You'll use them and you see they just don't work, all right? Your primary intervention, sorry, that is your evaluation, but your primary intervention is suctioning. These are smaller children that simply can't create the intrathoracic pressure to cough. They can't clear their own airways. And these are pretty viscous mucus secretions. You will see an enormous change in respiratory pattern by simply suctioning them. And sometimes you have to deep suction them, right? But that is your primary intervention. Bronchodilators have very little place. You'll see they won't work. The other thing, a little known fact about bronchodilators is you really don't have the receptors for them, or at least much of that. It doesn't have its full effect till after 6 months of age. So I see all the time asthma medications, albuterol tried in kids that are 3-4 months old. It's not going to work, not just because it's bronchiolitis, but it's not going to work because physiologically they don't have the receptors to make it work. Bronchodilators don't work until after 6 months of age. All right? Supplemental O2, high flow nasal cannula. What does high flow nasal cannula do? In addition to adding oxygen, what else does high flow nasal cannula offer you? Pressure. Again, it offers you that PEEP, right? So it's constant airway pressure even when they're expiring. All right, so that's bronchiolitis. Any questions about bronchiolitis? 4-month-old. Remember that the most common cause of lower airway findings in children in general is viral, not bacterial. The other thing to know about bronchiolitis, usually, almost always doesn't have a concomitant bacterial infection, all right? So often I'll see, oh, kid looked like he had an ear infection, urinary tract infection. 99% of the time, it is an isolated viral finding and viral disease. Very, very rarely does it have a concomitant bacterial infection going along with it, all right? Airway suctioning is your number one. There's no place for steroids, no place for bronchodilators. Every now and then, I'll get a 12-month-old or a 16-month-old with who's got a history of eczema, asthma, where I will trial a bronchodilator, and if it helps, I'll use it, and then I'll consider steroids. But for a 4-month-old X28-weeker, it's probably straightforward. No steroids, no bronchodilators, supportive care with oxygen, suctioning. Hydration is very important in these kids. A lot of increased insensible losses. They're breathing really, really fast. The other thing is it's really dangerous for them to drink when you're breathing 70 breaths a minute. So sometimes you'll make these kids NPO just because they can't handle drinking when they're breathing that fast. So hydration status is very important. Next case. 5-year-old male presents to the ER with fever, cough, and intermittent right-sided chest pain, times 3 days. He is mildly tachypnic, but does not appear to be in respiratory distress. On exam, you auscultate bronchial breath sounds on the right middle lobe. I'm sorry if this is rudimentary for you, but I need to go over this for a second because it's a pet peeve of mine, and I see it a lot when people present to me physical exam. When you describe your physical exam to anybody, to yourselves, right, what's the first thing you describe? And I'm sorry to take you back to your basic training here. You're presenting to an attending or your supervisor, and you are specifically gotten to the lung exam. How do you describe it? Anybody speak up. I know I preface this by saying it's pet peeve, so people are nervous, but whatever. We're here to learn. So how do you describe your lung exam? What do we start with? Anybody?
Rate.
What's that? Respiratory rate. Great. Excellent. What else? We observe, right? So we're looking at the rate. We're looking to see that there's normal chest expansion. We're looking to see that it is symmetric, all right? And only afterwards do we get to our auscultation, right? And when we listen, what's the first thing we describe? Do we say clear to auscultation bilaterally? Is that the first thing we say? No, please, never do that. When you get to your fast notes, everybody writes that. But at the beginning of your training, particularly the beginning of your careers, try to remind yourself of this, that the first thing you have to say is that there's good air entry in all lung fields. Because you can't have cleared auscultation, you can't have adventitious sounds unless you have air movement, all right? So always please describe that there is air movement in all lung fields. Your 14 to 18-year-old that comes in asthmatic, that doesn't have a helicopter parent watching their respiratory status all the time, they come in deep trouble. They're the ones that have had symptoms for 2 weeks. They come in and you listen to them and you know what you hear nothing. Because they've waited 2 to 3 weeks to present. And so you will listen to them and you won't hear adventitious sounds, you won't hear wheezing, you won't hear rhonchi, you'll hear nothing. And you might describe to your attending, it was clear auscultation, I didn't hear anything. But it's important to remember a way to have to listen for breath sounds first, all right? How do you describe breath sounds? What are they described at? I'm gonna throw out a couple old school words here, and one of them I put up there on the screen. When you have breath sounds at your bases, how do you describe breath sounds at your bases? Anybody? Vesicular, right? Those are called vesicular breath sounds, all right? When you listen over the trachea and the bronchi, what do we call those? We call those bronchial breath sounds. So now I'm telling you, you have a case where you auscultate bronchial breath sounds in the right middle lobe. Should you be hearing bronchial breath sounds in the right middle lobe? No, you should be hearing vesicular breath sounds. So you listen and you hear bronchial breath sounds, they sound really loud. Your vesicular breath sounds are very soft, they're lower pitched, you don't hear much in expiration. Bronchial breath sounds you hear on an inspiration and expiration, and somebody put your stethoscope over your trachea, over your bronchi, and listen to those sounds. You shouldn't be hearing them down here. What do they mean when you hear them in the wrong place? Anybody? It means increased transmission of sound. If you're hearing loud breath sounds, it means that there's some form of consolidation where it shouldn't be, right? Something is consolidated, sound moves quicker through it, it reverberates more. You're hearing bronchial breath sounds, that's a sign of a consolidation of focality, all right? So in this case, you hear a focality in the right middle lobe. What do you think? Your differential diagnosis, again, is all the same stuff we went through before. This kid had pneumonia. Very important, what I want you to know when you're making a distinction between adults and children, the most common cause of pneumonia in all kids under 5, we're all tempted to treat them with antibiotics, but by far the most common cause of pneumonia in kids under 5, and this is a take-home point from this entire slide, are viruses. And so they won't respond to antibiotics. The basic distinction that you make between viral etiology and viral infections can have focality, but in general, usually they're pretty dispersed, they're interstitial, they're all over the place, they're diffuse. If they're focal, that's when you start to think bacterial. But in general, kids under 5, viral. Kids over 5, that's when you get to your strep pneumo, and about 20% of kids have or maybe more than that, 20 to 40% mycoplasma. That's your atypical pneumonia. Let's move forward. 6-year-old male presents to the ER with vomiting, diarrhea, and diffuse hives after a shrimp ingestion. No respiratory symptoms. He's got vomiting, diarrhea, and diffuse hives after eating shrimp. What's your diagnosis? Allergy. Good call. You said allergies. The reason why you picked allergy, would you call this anaphylaxis or would you just call it severe allergy?
Severe allergy right now.
Call it severe allergy. Anybody else?
There's no respiratory symptoms, so it's not. It's more than one system. It's anaphylaxis.
So it's anaphylaxis. Great. Excellent. So anaphylaxis, right? Severe allergic reactions or anaphylaxis is by definition, if you look it up, all it needs is 2 systems. What are the 4 most common systems involved in anaphylaxis? Well, we got 2 of them right here. We got skin, GI, cardiovascular, right? And respiratory, right? If you have 2 of any of those, anaphylaxis right off the bat. So this kid that has vomiting, diarrhea, and it makes a difference, right? To call this an allergic reaction versus calling a severe allergic reaction versus anaphylaxis makes a difference in terms of how you're going to intervene. So if you just call this a severe allergy, and you might buy yourself time, you might just put this kid on Benadryl and some steroids and watch him or send him home. But if we now have defined it as a 2-system involvement, it's anaphylaxis, that makes a difference in the way we intervene. Why? What medication is our staple for anaphylaxis? Pull out your epi. By the way, we've been seeing a lot of kids come into our office because of the upsurge in price for epinephrine, $600 or something like that. So parents are now thinking twice before they use epi, or they simply aren't buying it because they can't afford it because $600 is ridiculous. And so we've been seeing an upsurge and an uptick in the number of people that have just been showing up to our office in anaphylaxis. And we've been, do you know how much one of those vials costs us? I mean, it costs us nothing. And we've been administering epinephrine in the office because of that. So you might see it more. You might see it more in the ER. It's upsetting. It's very upsetting. All right. So making that 2-system discernment very important. IgE mediated is your main cause of anaphylaxis. 50% of them are food allergies. Pathophysiology, right? You just have to understand that basically you have these mast cells that are sitting there. You have an initial sensitization where your body makes IgE. It attaches itself to the mast cell, then the next time it's exposed to that antigen, bam, massive release of all these inflammatory mediators, the main one being histamine, and histamine, tryptase, all these other ones, nitrous oxide. I give you a nauseating slide that kind of goes through them, which we won't go through, but it diffuses to those major systems, and that's responsible for all the symptoms that you see. All right? I put up there diagnostic definitions. I made it small deliberately so that you couldn't see it, but basically what I want you to know is two-system involvement should make you think right off the bat. This kid's got diarrhea, vomiting, and hives, anaphylaxis. Don't think about it. Give that kid epinephrine, okay? And then you have time to give steroids. Remember, steroids are more long-acting. You use your H1, your H2 blockers. Are you going to observe them? Are you going to hospitalize them? What are you going to do with them after you administer? You've decided this is epinephrine. You've made the clinical call. What are you going to do with them? And why? Are you going to send them home?
You observe them for 2 to 4 hours or 4 to 6, depending on where you are, and you have to look for a rebound.
Excellent, right? So I was going to say they're asymptomatic. Why are you still watching them? Because there's a possible rebound. And rebounds can happen up to 24 to 72 hours afterwards. 99% of them happen in the first 24 hours. Sometimes, depending on the severity, I'll even hospitalize these kids up till 24 hours and then send them home on a 3 to 5 day course that I can sleep well at night of Benadryl and dexamethasone or Decadron to know that I'm covering them for that full time period where rebound can occur. All right, so even if they're asymptomatic, and epinephrine is miraculous. Has anybody seen reversal of anaphylaxis before with epinephrine? It's pretty incredible. It works. That stuff works. It works really, really well. And they can become asymptomatic relatively quickly. You still have to watch them for that rebound effect. Treatment, yada, yada. So epinephrine, Decadron, H1H2 blockers, right? So everyone's like, why do you need the H2 blockers? Why Pepsid? Because actually it works synergistically with Benadryl. So you use H1 and H2 blockers when you're dealing with anaphylaxis, not just the Benadryl, not just the antihistamine. I'm over time. I'm going to stop there. I want to know if anybody has, because I know you guys have a really, really packed day. Does anybody have any questions about anything that I've gone through? I'm sorry that I didn't get to the rest of the cases. Zach has all of my contact information. Consider me your pediatric resource. If you guys have questions or concerns or you want to go through the slides and you find something that's confusing, by all means, I urge you to reach out to me and ask any questions that you have. Thank you for your time.